let's just get started. We'll get right into it. No need to dilly-dally, as I tell my children all the time. So this webinar is really intended for small businesses that either may not have benefits at all, and you feel like it's time to get started. It's time to start investing in your workforce, or maybe you have a strategy, but it is breaking the bank and you want to find out how to do it a bit differently. So my name is Christy Gupton, and I am an employee benefits advisor. I host a podcast called Healthcare Solutions. I'm really into the free market side of the healthcare system. I really appreciate independent, local, physician-owned types of primary care, and direct primary care is certainly my favorite thing in healthcare. So I speak here and there at DPC Alliance events. I've spoken at a mastermind in Greenville, South Carolina, and then I've spoken at the National DPC Alliance Conference twice. I just spoke at the one they held in Minneapolis about one of the case studies I presented there was what we're going to really dig into today. And so you'll always find me kind of seeking different ways to crack this thing open and make it transparent and make it better. My guest expert today is a benefits attorney, Jason Cogdill. We work together very closely. I depend on him for legal advice for my clients, and he's just a great guy. I've always thought, being in ministry and also being a demon didn't quite fit together, but Jason, you went to both undergrad and law school at Wake Forest University, right?
That's right, Christy. I'm a double D, as they say, and I was just thinking that one picture of me would have been one too many. Two's a bit much, so we need to quickly move this thing along.
Yeah, right. I got it. On it. I'm on it. Here we go. So, jumping right in, we're going to try to leave as much as possible for Q&A also at the end, but don't forget, if you're putting questions in the Q&A box, we're going to answer them along the way. The reason why you want a benefits strategy is because you want your employees to stay healthy. They can't come to work and help your small business grow if they're not well. So let's uncover a way for you to put together a benefit strategy that doesn't break the bank. There really are a lot of different options. This one I don't recommend. Do nothing and see what happens. I think that's a faulty strategy. Nothing could be worse than you having a great, reliable, loyal employee, and something happens. Maybe they end up in the ER, or even sometimes just a simple primary care visit that ended up with a big bill, and they probably say to themselves, I really like my job and I like who I work with, and it's all great, but I'm going to have to go somewhere with insurance. I just think that you need a strategy. Doing nothing and not having anything is faulty. Another option is you could buy a traditional insurance plan and then just brace yourself for the year-over-year premium increases that you're going to see. And you are going to see year-over-year premium increases. It is inevitable. The way the traditional health insurance system works is through year-over-year premium increases. They don't operate on a deficit under last year's revenue. They have to continue to grow, and that means you have to pay them more. It's just inevitable. Don't fool yourself into believing that if you buy a big, traditional insurance plan from someone like Blue Cross or United Healthcare, Cigna, or Aetna, don't think you're going to be able to keep that stable. There's these things called MEC plans. Some people call them skinny plans. They don't cover a lot, and they're honestly very cheap, but I think that it puts employees in a difficult position because it just doesn't cover a lot. Most of them just have one preventive care visit per year, and then maybe open-ended sort of access to hospital care. You can provide that for still a very affordable price, but not get into those skinny plans. I think those are tough. All right. You could contribute to a tax-advantaged account like a health reimbursement arrangement and allow employees a framework to use those dollars to buy their own personal health care strategy. We like this option. We also like this one: sponsor a self-funded plan and assume a measured amount of risk, but you do need to be prepared to comply with the rules and regulations associated with self-funding. Today's webinar is just going to focus on one strategy, this one. Okay, we will do a webinar sometime in the future about self-funding because we like that strategy too, but it's useful for a certain size, a certain critical mass of employees that makes that work. I personally think that's right around the 30 to 40 employee mark where you can make self-funding work, but it takes attention, it takes attention to detail. So for today, we're just going to focus on one strategy. So I see it as like a 4-point strategy where direct primary care is your first stop in any healthcare encounter. I like to think of direct primary care as my personal physician on speed dial. I do not make a move in the healthcare system without either texting or calling my direct primary care doctor. And he always has, my best interests at heart. I pay him a membership fee, so there's no need for him to have to get paid for any encounter. He's already paid. And so that means he can just focus on me. So below that, being that direct primary care, in my mind, is the most important element, we put that first. And then below that are 2 account-based tools. One is a health reimbursement arrangement called an ICHRA. It's for individual coverage on the marketplace. I'll explain that a little bit more. And then the other is a flexible spending account. So we're going to talk about both of those in great detail. And then the last point of the 4-point strategy is a health share called Sedera. Okay, moving on. So a few things about direct primary care, which most of you probably already know. Instead of filing insurance claims to be reimbursed for that any encounter, just on a very affordable monthly membership covers the needs. No insurance is really needed. Access, I hesitate to call it 24/7 because doctors need to sleep too, but access after hours and on weekends and holidays is just part of direct primary care. Actually, it was last weekend before last. I was telling my doctor, hey, and his name is Dr. Kramer. Dr. Kramer, I'm sorry. Every time it seems like I get sick is on a Saturday. And he's always saying, that's what I'm here for. So most patients are encouraged to text or call or email directly to their physician. So I'm putting no barriers in place. Common prescriptions like generics and lifestyle type drugs that you take to just manage a chronic disease. Sometimes those are dispensed in-house, which is a great help. Big discounts on services inside direct primary care like labs. And sometimes they'll have imaging agreements with either a local imaging place, or maybe they even have an x-ray machine in their office. Referrals when needed, but good news is it's seldom needed. This is personalized care, and approximately $75 a month per patient is the national average. Many practices that I see will have costs for adults and then some lower costs for kids, or even a family cap. I've seen that too. So altogether, a much smarter, better access, better outcomes, and lower price for more personalized care than going through an insurance policy to access a network full of doctors. think about it like this. When you need a great primary care doctor, how many do you need? My answer is you only need one really good one. So why do you pay for a network full of doctors when you really only need one primary care? And then if that primary care doctor can give you smart, measured direction into the world of specialists or facilities or other things like that, then that's really all you need. Having a huge PPO network given to you by an insurance company, not all that needed. Jason, I know that you might have a word or two to say, but if you don't on this slide, it's okay.
Thanks, Christy. I made a joke earlier, but it's good to be with everybody. And I think from a compliance standpoint, my view of direct primary care is that it's not an insurance policy. It's not a formal plan as the state or the federal government would see it. It's really just a contract relationship between patient and doctor. And so as a compliance person, I see that means great flexibility. You know, you connect with the doctor you want to connect with. They outline what services are available. You know, they outline how those services are going to be provided. You know what you're paying for. So it's much more like subscribing to a service we're used to. So from a compliance standpoint, one thing I like about this is just the simplicity of it. And it's really just a doctor-patient relationship without insurance, without, you know, some of the things that can tend to complicate these matters when it comes to billing through insurance and whatnot. And certainly from a big picture perspective, and Chris is going to say more about DPC and the other thing, from a big picture perspective, I think, you know, one thing I like about Christy's model, and it is alternative and creative and effective, is that, you know, in working with small employers, for-profit, nonprofit, churches, you know, see it all. A common theme among some of those small employers is, if they're not offering benefits, is they may use the phrase, we like being out of the insurance business, meaning we don't want to deal with these behemoths that we don't know. We don't have any leveraging power for cost, as Christy alluded earlier. Everything Christy's talking about today are things that are not insurance. They're not through an insurance carrier, which again leads to flexibility and cost savings and really lower effort for the employer in terms of compliance with state and federal rules that go along with formal insurance plans and policies. There's some exceptions to that when we talk about ICHRA, and we will, but you know, that's another reason from a compliance standpoint. You know, I don't need to say a lot because there are not a lot of rules, not a lot of complexities we need to deal with, particularly when it comes to DPC. And then, as she'll discuss it later, the healthcare sharing model.
So I put this picture in here. This is our doctor, Dr. Kramer. This is my youngest. His name is Slade. And this was a couple years ago when I'd signed him up for his first overnight, you know, week-long summer camp, you know, pack your crate and all your stuff and head off away from mom and dad for the first time. And so I use this picture just to explain that the thing that direct primary care has over all other forms of healthcare is time. They have time on their side. So all the preparation that was happening to get this child of mine ready for camp, and whenever I would ask him if he was excited and thought he was going to have fun, he'd always change the subject. But when Dr. Kramer asked him, he revealed that no, he was not excited to go to camp and didn't want to go. And so they talked through it, and their conversation on just that point alone probably lasted 10 minutes. The appointment probably lasted about an hour, where they covered a lot of territory. But I remember Dr. Kramer gave Slade a good tip on how to be more comfortable away from mom and dad, and that was to stuff your teddy bear way down in the sleeping bag at the bottom and roll it up so that it wouldn't look to the other campers like he needed to sleep with a teddy bear. And then that way he could judge and determine whether his other cabin mates brought their teddy bears too. And if they did, then great, he was in a safe place. But if they didn't, nobody had to know the difference. So, I mean, how often can you really get into that intimate of a conversation with a care provider in the traditional 7 minutes or so that you have in fee for service. Okay, moving on. So we said that there are some account-based strategies that help supplement the direct primary care part of this 4-point strategy that I'm trying to lay out for you. So a health reimbursement arrangement is one of them. This particular version of it is called an ICHRA. That IC stands for individual coverage. And then of course, HRA stands for health reimbursement arrangement. So employers contribute to HRAs, not employees, but the money that you put into a health reimbursement arrangement allows employees to be reimbursed with tax-free dollars. You do get to define the list of services, like if you want the DPC membership to be reimbursed to employees through your HRA, you just simply define that in the list. And it also can include individual coverage on the marketplace. So that was sort of the point, the reason why the government established this type of health reimbursement arrangement, is because group insurance was just on a huge upward trajectory in terms of cost. The electorate was crying out and saying, why can't we just go buy our own insurance and let employers help us with cost? And so an ICHRA is, at least in part, for individual coverage, where you can give employees dollars to spend and they go shop on the marketplace. In my personal opinion, with this 4-point strategy, I think individual coverage is really a good thing for employees who have pre-existing conditions where a health share might not serve them as well as an individual policy. And let's face it, we as taxpayers are funding the government to give those big insurance companies that are approved on your state's marketplace the ability, the extra money to take on pre-existing conditions. So we're already paying for it. If you have an employee in your workforce that has a serious medical condition that they're dealing with, then the individual marketplace might be a better space for them, and you can help give them money to reimburse themselves out of if they go shop on the marketplace. However, it does knock them out of being eligible for a subsidy. So Jason will talk about that in just a second. It also, having an ICHRA in place helps you satisfy the employer mandate. So if you do have more than 50 full-time eligibles and you're considered an applicable large employer and subject to the employer mandate and penalties if you don't have a plan, then establishing an ICHRA checks that box for you and keeps you out of penalty territory. And there's some extra detail that goes into that, but we'll touch on that. It does have its own plan document, so you can you have the flexibility to actually define the benefits and establish how the reimbursement process works. It does need a third-party administrator because, let's face it, there's probably going to be some health information that is exchanged between employees and whatever entity is reimbursing them. I happen to be a third-party administrator, so I'll go ahead and tell you that I can handle that for you. And my firm retains Jason to help me with, off the wall questions. So I'm certainly an advocate for employers not administering an HRA on their own. It's allowable, but I don't think it's advisable. And lastly, I do help my clients prepare these reports and help them determine what they should pay, but there is a fee because an HRA is considered a self-funded health plan under ERISA. It's not insurance, it's just a plan. So at a certain time, usually the end of July or August every year, a $3 per member per year fee is due to the PCORI, stands for Patient Centered Outcomes Research Institute. was part of the Affordable Care Act. So if you're my client, I help you prepare that report and determine what you pay. So Jason, bring in the technical aspect of ICRAs based on what we've said so far.
If you're listening today and you're not familiar with the name ICRA, it's a terrible acronym, but of course in benefits and healthcare, we love our crazy acronyms. So as Christy said, individual coverage health reimbursement account. Health reimbursement account means employer money. So this is a way for the employer to fund coverage without having a group insurance plan, no small group, Blue Cross, Aetna, United Healthcare plan, but the employer is funding on a tax-free basis coverage that the employee is getting outside of that group setting. Before the ICRA was established in 2020, and before that, a few years earlier, there was another bad acronym, QSERA, Qualified Small Employer Health Reimbursement Arrangement. This was true. There was no way for an employer to fund individual health coverage on a tax-free basis and still be within the rules. And this is a misnomer within the market of small employers across America. And this is not uncommon for me to talk to a small employer that says they either have in the past or present just let employees go get their own individual coverage, and then the employer just reimbursed them and did not tax them on that amount. That's not within the rules. One of the many things that the Affordable Care Act did when it was passed in 2010, and then when the regulations started coming out after that, was make it clear that an employer cannot directly pay to the carrier or reimburse individual, meaning non-group health insurance on a tax-free basis. So that was the case throughout the 2010s. Then in 2016, I think it was, the QSERA was adopted. 2020, the ICRA was adopted. So now this means an employer can use employer money to reimburse coverage such as an individual health plan that a person goes and gets directly from the carrier, as Christy mentioned, which of course those individual plans have to follow all the ACA rules, including one big one she mentioned, that the carrier can't disqualify any pre-existing conditions. It's basically, open enrollment with no medical underwriting for all those plans. And she's going to talk about another coverage model that may even be better than that for some employers that can be reimbursed through an ICRA. But as you think about, as the employers, you think about budgeting, as you think about what employer dollars, either you're already setting aside for people, it's just part of their taxable compensation package. So what part of that you may want to shift the benefits so that it's tax-free, or if you have nothing and you've just been using the lump sum model and there's really nothing specifically budgeted in. So some of this will be new cost as you think about that. I mean, ideally, the employer money that's going to be used will be tax-free, meaning the employee receives it. It doesn't show up on the W-2. It's exempt from federal and state income tax and FICA. And then, as those of you know who have anything to do with your organization's finances, that when you pay an employee $1 of tax-free money, the employer doesn't have to match that 7.65 FICA. So this means that what the dollars that an employer would set aside, for example, in an ICRA, and those amount, it can be any amount, and it can be handled on a monthly basis or an annual basis. I would say most employers are probably using somewhere between $200 and $1,000 per month that goes effectively into this account and then goes to the employee on a tax-free basis. So the amount of tax savings, even on a small number of employees, can be significant. And again, flexibility is the key, just like with the direct primary care model, because the ICRA can reimburse just individual premiums, or it could reimburse direct primary care, some other things Chris will mention. It can reimburse, if the employer chooses, completely the employer's option, any out-of-pocket medical expenses, which would mean prescription drugs, co-pays, deductible expenses, dental expenses, vision expenses. Those are eligible to be reimbursed through the ICRA if the employer wants. So there's a high degree of flexibility. This is not a one size fits all. This is a many sizes fit whatever the employer wants to do within the rules. So this is a relatively new model. A lot of small employers are using it. Many, many more will use it in the next 5 to 10 years. It's, this is, I think, only the 4th calendar year that an employer could use one. But this is certainly one of the models that we spend the most time talking to small employers about?
Just in case you're wondering why I chose a car as the icon for this. Well, first of all, PowerPoint doesn't understand what an HRA is and doesn't have an applicable icon that made sense. So I thought, you know what, ICHRA is kind of like a vehicle that helps the employee get from where they are to where they want to be in terms of coverage. So that's why I chose that. Okay, next up, Jason, talk a little bit about classes. So it's important when you're determining eligibility for this benefit strategy that you have a defined set of classes. You can't just say, we can only offer this, or we offer this to just who we want to, right? Not exactly. I think you need to have defined classes. So Jason, give folks some best practices around that.
Many times for a small employer, group health insurance from the big carrier feels like one size fits all. For example, as a pointy-headed compliance geek, I have to review a lot of documents from the carriers, and 99% of every carrier booklet I've ever looked at had this definition for eligibility: individuals who are active and full-time with a regular weekly schedule of 30 hours or more. That's standard. And if an employer wants to use a different one, they have to have a back and forth with the carrier and the stop loss provider. It's painful. So one question about eligibility is whom do we have to cover? And another issue is who can we cover? So for example, if an employer has a small group, traditional group health insurance plan, and the employer wants to offer that to 25-hour, 20-hour week employees, the employer can't do it. Carrier won't allow it. With the ICHRA, as with the direct primary care model, any employee can get that, from the people working 5 hours a week part-time to, it's up to the employer. The employer gets to choose who are we going to offer this benefit, whom are we going to offer this benefit to, what are they going to be eligible for. And for example, if it's an ICHRA and the employer wants to provide some money to the part-time people, but not as much money as they provided the full-time or the senior management, that's an option under the ICHRA compliance rules. So again, the theme here is flexibility. Are there some compliance rules we have to follow as outlined by Christy's bullet points here? Yes. Are they painful? No. But the key here is flexibility in what we want to provide and to whom we want to provide it.
One of the things that I do for my clients is we schedule at least an hour of sort of planning and creating the framework around what will become your plan document. And that hour is scheduled with both me and Jason. So you have access to, me as an advisor, Jason as an attorney, to help you define and determine how your plan document will be written. But the important thing is that it is defined and written. And you sign off on it, it becomes your plan. And there's no questions about it. No employees can say, well, wait a minute, that employee got this, but I'm only getting the other thing. And so if you don't want to have to defend on the fly your strategy, then it needs to be defined and it needs to be written and it needs to become your plan. That's what your plan document is. It is the definition of what your plan is. Anything else, Jason, before we go to the next slide?
No.
Okay. Next, this is point number 3 in the 4-point strategy. What is a flexible spending account? It first became a thing in 1986, way back when Reagan was president. So it's not new. It is a tried and true version of an employee benefit. Employees contribute to it, and they usually use it to reimburse themselves for qualified out-of-pocket medical expenses that are defined in Section 213D of the Internal Revenue Code. This year, and ever since the Affordable Care Act was passed, they use, I guess, what do you call the, and I guess inflation rules or something. They ratchet up the allocation maximum a little bit every year. So this year it's $3,050 that employees can exempt out of their own income They rely on you to help them with the accounting piece and the payroll system, but they can set aside up to $3,050 tax-free. That means no federal, state, or FICA tax. That also means you don't have to match that FICA. And that's a tax savings for you. So FSAs are a good thing. If you want the layperson's version of what is an eligible medical expense, you can go to irs.gov and search publication 502. And that way you don't have to read the law. You can just read a publication, but it's official because it comes from the IRS. There are use it or lose it rules that apply to flexible spending accounts, and that's what kind of makes them somewhat different from health savings accounts, which happened under a different law. But I will tell you that we're having some difficulty getting the IRS to make sure that health savings accounts and direct primary care both play well in the sandbox. And so far, they are not willing to issue those opinions. So for right now, my opinion as an advisor is that this ICHRA FSA strategy is a better one that fits with direct primary care. Even though the use it or lose it rule applies, that should not hinder anyone, because the right administrator with the right education and the right attention to detail and the right reporting and ease of use, that forfeiture rate should be less than 1%. I say that because I am an administrator, and that is my forfeiture rate. It's less than 1%. But I spend a lot of time educating employees, communicating with them, making sure they know how much money is left in their flexible spending account and what time frame they have to reimburse themselves out of it. And when it comes right down to the last few days before the deadline, I'm just a pest. I just pester them every single day and I say, did you go out and buy some of these things that I know you need based on conversations that we've had? And so that's why. So when you've got a good administrator, you should not be afraid of the use it or lose it rule. When employees have a good administrator and they have lots of dialogue between them and who is reimbursing their request, they report a high level of satisfaction with the flexible spending account as a benefit. Conversely, when the administrator is sort of checked out and sort of just doing the minimum amount of work that they can do to say that they are an administrator, there are employees who say, I hate that flexible spending account because I lost money in it. Well, I want you to know that a good administrator makes all the difference. And I'm one of those. I'm proud to say that I can do it the right way. So Jason, any thoughts on what we've got here about flexible spending accounts?
FSAs have been around a long time. Many of you are familiar with them either through an employer option you have had or spouse has had. Frankly, this is a tax break that just can't be ignored, because it's almost easy money, especially because all of us, whether our household is 1, 2, 3 or more people, are having out-of-pocket health expenses. So if we can pay for those with non-taxable income, and again, save the federal, state, FICA, which, on average across all working Americans, I mean, that's 30% of every dollar if it's not taxed, So again, back to the big picture. I mentioned, part of this question is employer money. What employer money is going to be dedicated to benefits, and can we make it non-taxable, such as if the employer is paying part of the DPC, that would not be taxed with the employee. If the employer is putting money in ICHRA to be funded for employee premiums or employee out of pocket, that would be non-taxable. This is the way that employee money would not be taxable. So just as a quick example, and I'm going to use some easy numbers to make the math easy on the fly. And that is, let's say hypothetically the employer, does a DPC model, whether or not it pays any toward the monthly memberships for the employees. It allows that option, and employees can use that. The employer decides to fund for full-time employees $500 a month. Or it can be less, it can be more, but let's just say $500 a month that can go toward, again, all those things we mentioned. That $500 a month that the employers provide employees would be tax-free to the employee. So using the 30% estimate, that means, employees would be saving on their income $150 a month that they don't have to pay in taxes because they're getting that from the employer and non-taxable. In addition, this option to use an FSA, a health FSA for out-of-pocket medical, dental, vision, means the employer would allow the employee to payroll deduct money into the FSA and then be reimbursed. It can all be reimbursed quickly, or it can be spread throughout the year. And let's say the employee decided to fully fund the health FSA, which I'm doing, my wife is doing technically through her employer, fully fund the FSA for 2023 on a calendar year for us. And so, that means our monthly contribution pre-tax from her paycheck is, I'm just going to call it $250 a month. The max is $3,050, not $3,000, but let's just call it $250 a month. So broken up into however many paychecks. Well, if $250 a month is deducted from her paycheck pre-tax and we're reimbursed separately, using the 15% rule, again, that's $75 a month in tax savings. So when we add that back to the ICHRA, we're talking $225 a month tax savings to help our benefit. So the dollars are going farther for the employer, they're going farther for the employee. There's a question that popped into the box. What is forfeiture? There is a strange, odd, terrible, old rule that's been around, as Christy said, for 40 years, and it's called use it or lose it. Basically, originally, when these plans were designed, the IRS said, we're going to give you this tax break. It's almost too good to be true, employees. And back then, there was no maximum amount. People could put 10,000, 20,000. So to control the maximum, the IRS said, whatever you put in the account and you don't spend in a particular year, you don't get it back. It just reverts to the employer. It's not a great rule. It's never been overturned, except the IRS has allowed some things to soften that. More things are eligible than they used to be, including over-the-counter medications. There's an opportunity for carryover that you can carry over up to a certain amount to the next year. The reimbursement, for a whole lot of reasons that Christy didn't get into, but people are not losing money out of these accounts. Some of you have done it. I don't need to tell you stories, but all I'll say is for my family, we're fully funding the account, and we pretty much spend it all in the first half of the year. So losing money is really not an issue. So the good news for us is we maximized the tax savings and spent all the money. The bad news is we could have used double the amount of maximum if the IRS had allowed it this year. But again, big picture is this is how employees can get more skin in the game, as people love that phrase. The employees can participate in a way that helps them save money on taxes. And the big picture again is the rising tide, because more healthcare, more benefits, compensation, net compensation increasing is helping everybody as we try to accomplish those goals that she outlined at the beginning.
Just as a reiteration, employers contribute to the ICHRA, employees contribute to the FSA. So not only does it help the employees get an additional tax advantage from using their own pre-tax income, but it also takes the pressure off of employers. You shouldn't feel like you have to fund every single expense of your employees. So if you simply define what you want the ICHRA to reimburse them for, and then you give them their access to their own pre-tax dollars through a flexible spending account to reimburse for out-of-pocket expenses, then you can do that. However, I will say this, and Jason, think of the right technical way to describe it, but if you don't do the ICHRA, then you can't offer the FSA. So it's the ICHRA that helps your plan meet minimum essential coverage and helps you do some of these things without having a bona fide, qualified group health plan. So don't think that these two things are separate. You can have one without the other, or you can have the FSA without the ICHRA. You can't do that. Jason, say that better than I just did.
Unfortunately, there's probably not a way to. There's some technical rules I won't bore you with that effectively say, that again, whenever we're talking about tax benefits, there are some strings attached in the way of rules that need to be followed. For example, on the ICRA, as Christy mentioned, for an employer to offer an ICRA, the employees who are going to benefit for the ICRA, they have to have health coverage. You know, they either have to have it through spouse employer, they have to get an individual health plan, they have to have the healthcare sharing model Christy is going to talk about in a moment to be able to have the ICRA. To have an FSA, you know, I get the question a lot from a small employer. We don't have any benefits. Can we offer an FSA? Well, they should be able to. Unfortunately, the answer is no. If you don't have either a group health plan or an ICRA or certain other things, you can't have an FSA. It doesn't operate as an island. So all the, you know, one reason Christy's laid this out as she has is that these things work well together. They play well together in the sandbox, but particularly these two, because if you don't have an ICRA to have an FSA, you've got to have a group health plan. If you don't have a group health plan, you don't have ICRA, you can't have an FSA. So that's all I got, Christy.
Yeah, I know it. I don't agree with it, like I know you don't, because it used to be the case that FSAs could stand alone, but it was after the Affordable Care Act that changed. So we have to work within the framework that the government gives us. Okay, moving on. We are going to talk about Sedera. Sedera is a health sharing community. It operates across state lines. There are no networks. You get certainly big discounts by being a cash pay patient, since, you know, Sedera is not insurance. It's a health sharing community. And as I go through this description, I want you to know that I was covered under my husband's health insurance for 20 years. The Blue Cross of North Carolina was the card I carried around in my wallet. Well, 3 years ago, I decided I had had enough of that. And I chose, after doing about a year-long vetting process, I chose Sedera for me and my boys. We told my husband we were leaving him on his poor excuse of a health plan through his employer, and he'll just have to be fine with that. But we were going in our own direction, and I've never been happier with my healthcare choices. And so I'm eating my own dog food here. I wouldn't be presenting this to you today if I didn't think it was your best option. Sedera was founded by a doctor, and the first precursor to Sedera was a company called the Caris Group. If you want to look it up, it's called, or was, I think they've been acquired since then, but KARIS. And their whole MO was to negotiate high and unexpected medical bills for members down to a fair and reasonable price. So they have all this data, huge data repository, so that they can make sure that Sedera members are not being taken advantage of, especially with regards to large medical bills, you know, hospital bills and things like that. Sedera is also one of the few health shares out there that really values the direct care movement, and they give you discounts when you have a DPC relationship. So I think that's important. We're going to go through this in a little bit more detail, but I will tell you that I have a separate video that definitely hits every single point that you need to know. It's about a 45-minute video, so if I send it to you, you might have to watch it in phases. But we're going to hit the high points today, but if you want the big detailed video about Sedera, just let me know. I'll tell you that if you've used any of these companies, then you've already participated in the sharing economy. So if you've done an Airbnb or you've ridden in an Uber, then you've already participated in the sharing economy, right? So the fact that Sedera is not insurance, it really should not scare you at all. And some of the next slides will make that apparent. So just to state this again, Sedera is not insurance. In my opinion, for small groups and for individuals, I think it's better than insurance. And I wouldn't say that if I didn't have my own experience. I do. I have my own personal experience to put behind that statement. And so let's keep going. Here's how medical cost sharing works first. When you enroll, you select an IUA, that stands for initial unshareable amount. It's kind of like a deductible, but in the next slide, you're going to see how it's way better structured, so much smarter than a deductible was ever thought about being. Secondly, you open a sharing bank account so that the community's funds can be exchanged with you when you have a need. Thirdly, when you have a need, and I'll define that in the next slide, you open a member case in the member portal. You shop for the treatment or provider that you have, or for whatever you need. You receive the funds. Your exposure to the initial unshareable amount that you choose is up to 3 per year. I'm not saying you're limited to 3 needs. No, I'm saying that when you pay your initial unshareable amount, you only have to do that up to 3 times per year. Your exposure is capped. So the amount of money that you pay out is capped at a certain exposure. And then when the funds are shared with you, you go and pay your provider's bill and then go on with life. So that's kind of in a nutshell how medical cost sharing works. This diagram, this sort of circular diagram, helps us define what a need is. So like at the top, someone's broken their arm or their wrist. Then they go to the hospital, then they get x-rays, they might get surgery, then they have rehab. That whole care encounter is considered a need, as opposed to the way insurance handles it, where every single little diagnosis code is considered a claim. And that could go on and on, but at the end of the plan year, or really, just some date on the calendar, but certainly annually, that date resets and your deductible resets. It doesn't matter if you, and I want to tell you, this has happened to me twice. When both of my children were born, they were born close to the end of one plan year with my husband's insurance, and they remained in the hospital, or the medical need of that time continued to have billing codes and claims filed into the next plan year. So we, as a family, met 2 different maximum out-of-pocket amounts, but butted right up next to each other because of deductible reset on just some date on the calendar. That does not happen with Sedera. Your initial unshareable amount is per need. So I give webinars about this specifically sometimes, and I had my mom sort of unexpectedly on one of the webinars, and my mom is a breast cancer survivor. So she was diagnosed in 2018. Even still today, she takes a chemotherapy pill. And so by Sedera standards, her need would not have ended as of yet. So think about that. If she had been a Sedera member and chosen, say, $500 as her initial unshareable amount, and when she was diagnosed with breast cancer, she paid her $500, and then the rest of her need was shared with the community, and her need is still ongoing even yet today, because the standard, the definition of a need is that it's not resolved until you're 12 months symptom or treatment free. So that is set up way smarter than a deductible ever thought about being. Let me click through some of the points here. A need is 1 or more medical bills in an entire care continuum. You pay your initial unshareable amount per need, but like I said on the last slide, your exposure is capped to only having to pay that 3 times in a membership year, but it's still per need. Once you pay your IUA, you're eligible to receive funds from the Sedera community. And what I just said, if you have such an awful year that you have 4 needs in a 4 or more in a membership year, you're only expected to contribute your initial unshareable amount 3 times. Okay. Here's a real life example. On the left, let's just focus on the left for a second. This is a traditional health insurance plan with a $5,000 deductible and an HSA. This scenario is a child who has frequent ear infections and ends up getting tubes surgically placed in their ears. So ear infection number 1, the employee with the high deductible pays $60 for an appointment plus a prescription. Second ear infection, it's a little more serious, they get a shot. Third and fourth, and before you know it, the primary care doctor's like, you know, you probably need to see an ear, nose, and throat specialist and talk about how to, you know, put a stop to these ear infections. So they do that. They pay their copay to the specialist, and then they swallow up, you know, a big bill for the surgery. But they still never met their deductible. And so all the money that they paid out, plus the $21,000 a year in insurance premiums that they paid for family coverage, tallies up to $23,525. Now, on the right side, this is the scenario with same type of medical need, child, frequent ear infections, but we're putting this under the perspective of direct primary care plus Sedera. So ear infection number 1 is included in the membership, number 2, number 3, and 4. But let's say the DPC doctor agrees with the recommendation. Hey, maybe you need to see a specialist, and goes ahead and gives the patient, the employee, some encouragement. You know, I know a great ENT specialist over here on this side of town, and let me set it up for you, and that sort of thing. So maybe the specialist visit costs more than the average visit, but that's part of their $500 initial unshareable amount that they decided that they liked, or employers can decide which version of an IUA they want to contribute to. And all that's left in their IUA is another $250, which is applied to the surgery bill. Then they set up a need in their member portal, and they start receiving, after Sedera does its work on that, and they do a great job negotiating high medical bills, especially with hospitals, down to a fair and reasonable amount. So, but the point is the rest of the need is shared. And so the cost, the outlay of costs, I've tried to define that there for you at the bottom. The patient's initial unshareable amount, plus what they paid to be part of a DPC membership practice, and plus what they paid to be a member of Sedera. That's the total annual layout and cost for this scenario. And I think it's a way better option, especially considering as a cash pay patient, you're getting all kinds of important discounts way up front. Sedera is also helping negotiate prices down to reasonable amounts. And then after your initial unshareable amount is paid by you, the member, then the rest of the bill is shared. So the Kaiser Family Foundation, I pulled this the way I imported it into PowerPoint, kind of cut off the top, but there's just no end in sight for how much premiums and what employees need to contribute to a group health plan. As you can see, so from between 1999 and 2022, it's just ratcheted up and up and up and up every year. So I wouldn't expect that the scenario there on the left is going to go down in price ever. But I do believe there is a way to stabilize and do this better, where you have more personalized care, a relationship with primary care, not a transactional experience. And so that's why I wanted you to see this real life example. Jason, anything you want to add here?
No.
Okay. I pulled this up too as a picture I took of a screenshot I took of Net Promoter Score. I don't know if you know what a Net Promoter Score is, It's basically when you fill out any survey and you answer the question, on a scale of 1 to 10, how would you rate our company or our service or whatever it is you just bought from us? And how would you recommend it to a friend or family member? So if you've ever answered a question like that, that company was measuring the net promoter score that you would give, to evaluate. Well, it's a little blurry, but I'll tell you that Aetna, their net promoter score is -56. And let me tell you how net promoter scores are valued. 0 is like the midpoint, and it goes all the way to -100 on the bad end, and it goes all the way up to +100 on the good end. So Aetna's at -56, United Health Group is at 5, Humana's at 12, and Anthem, which is a bunch of Blue Cross plans put together, and they've actually changed their name recently to Elevance, is at -1. So I texted my my contact with Sedera when we started this webinar, and I said, "Ooh, I forgot to look up your net promoter score." And he just texted me and he said it's 41. So people that use Sedera really do love it. The number 50 is considered an excellent score. So they're only 9 points away from being considered excellent, where as opposed to these big insurance companies, not so much. So I just thought you would be interested into hearing that. Tom says, I've been told by insurance salespeople that health shares in the past did not pay out for medical bills. How do you answer those concerns? Well, I'll tell you that that was some of what I evaluated. I took a year. I don't know if I said that clearly enough a couple slides ago. When I decided I wanted out of the traditional insurance game, I waited about 1 year and I sort of studied and I interviewed people and I looked at company financials for the health shares. I got on long Zoom calls where they tried to sell me on their process. And frankly, I probably evaluated 24 different health shares. I mean, all of them, all the recognizable names. And Sedera was the only one that satisfied all of my criteria. I'll tell you what I think is plaguing the other health shares that didn't meet my specifications is that they're not negotiating high cost medical bills down to a fair and reasonable price point. And I interviewed other people that I've helped move over to Sedera from other health shares, some of them DPC doctors. And they would tell me that, maybe hospital bills from when children have been born or something like that, high bills in the tens of thousands. The health share, it took them a very long time, like over a year, but they just paid it. And I think that is a faulty strategy all day long. You don't just pay a medical bill. You scrutinize it really heavily and you kick out things that don't make sense. We've caught all kinds of fraud, waste, and abuse. Of course, the hospital just calls it an error, a computer error. Sometimes, though, when those errors happen as often as they do, you have to wonder to yourself, is that really a mistake? Or did they put a diagnosis code for a circumcision on the birth of a baby girl on purpose, just because they thought nobody would look at it? So Sedera goes way beyond the call of duty to make sure they're scrutinizing medical bills, comparing it to the data, the extensive data repository that they have. In addition to comparing those diagnosis codes to Medicare reimbursement rates. So they're negotiating on your behalf down to a fair and reasonable price. And that is just a normal part of their everyday work. And not all health shares do that. As a matter of fact, some health shares choose to be part of a PPO network. And what is a PPO network? It's just a contract under which providers are paid. And when that contract is signed, you don't get any choice to negotiate. There is no negotiating in a PPO network contract. So if a hospital bills $100,000 for a hysterectomy, it is what it is. That's the contracted rate. And so any health share that uses a PPO network does not meet my criteria. Any health share that doesn't negotiate down to a fair and reasonable price, darn near Medicare reimbursement rates, also doesn't meet my criteria. And lastly, this is not all I looked at, but I think I've belabored the point enough. Any health share that doesn't truly embrace and put their money where their mouth is in the direct care movement, so direct primary care, direct specialty care, cash friendly facilities and outpatient surgery centers and all that sort of thing. They don't put a lot of resources into embracing the direct care movement, and then they don't meet my criteria either. So there's the only one that met mine, and that's part of the reason why I say that. So here are the public rates for Sedera, and they call it for teams. Sedera is really good about not using any words in the English language that would make you believe that they're anything like insurance. So they're not even using the word groups. They're using the word teams. So this is for employers with at least 3 employees that would like to participate in Sedera. So these rates are for employer groups of 3 or more. There is a separate rate structure for individuals, but if you have at least 3, these are the public rates, but you should know that Sedera gives you a 14.5% discount off of these rates if you have a direct primary care relationship. Again, they put their money where their mouth is when it comes to direct primary care. So, like I said earlier, the Kaiser Family Foundation puts, I think, over $12,000 a year now that they reported in the 2022 employer benefits study as the national average. So this strategy is coming so far under that that I really felt like it was important to lay it out to you the way that we have, a 4-point strategy, starting with direct primary care, giving employees access to 2 different accounts, one funded by you, one funded by them, and then Sedera. Now, in the longer, much more detailed video that I can send you if you like, I'll go into how Sedera handles pre-existing conditions. How do they handle everyday medications? How do they handle this? How do they handle that? I'll go through all that in the video, and I'll give you the materials and the collaterals that kind of go along with that. But I really feel like Sedera is a smart strategy. And I also am a person with pre-existing conditions, but they're chronic lifestyle disease related. And so what I didn't feel like I was a person with pre-ex that needed to stay in an insurance model. I really felt like what I really needed was a great primary care doctor. And I was able to get that when we alleviated ourselves of the high, we were paying $1,000 a month to Blue Cross of North Carolina for family coverage through my husband's employer. That doesn't even count what the employer was paying for him. So knowing and making the personal decision that my pre-existing conditions were not all that bad, that's a personal decision I made. So with your workforce, I would absolutely help coach your employees through that decision-making process, but ultimately it's their decision. So if they feel like they have pre-existing conditions and they really need to be in an insurance model that takes that without underwriting, then that's sort of what you're giving them access to, that vehicle, that ICHRA. You're giving them a ride in that vehicle that takes them from where they are to where they need to be in terms of coverage. But if they choose Sedera because they feel like that will work for them, then they've made their own personal decision, and I think it's a smart one. I want to share a video with you that is an insurance small business owner in Austin, Texas, and this is just his opinion. of Sedera as a benefit model for his workforce. I think he says in the video he has about a dozen employees.
My name is Jason McKinley, and we're in our home office at my insurance agency, M&D Insurance Services in Austin, Texas. We're a full service agency, so we'll do someone's homeowner's insurance, their commercial P&C, their benefits, obviously. I think the healthcare industry is broken. Everyone continues to get an increase in their premium every year. And a lot of times that increase comes with a decreased amount of coverage. Business owners love Sedera. Again, with the cost savings that come with it, the employees are the real winners, I believe. I love to help people, and I love to solve problems, and I love relationships. So in what I do, all that is encompassed. You know, with Sedera, sometimes I've got to apologize when I'm leaving and say, hey, I'm not trying to sell this to you. I'm passionate about it because it's worked for me, and it's worked for my family. You guys ready to shoot some hoops? I don't think what's happening today in this industry is sustainable. My hope is that we move more towards options like Sedera. Sedera is not insurance. It's an entirely different solution. It's got a different philosophy. And I like to say they take the middleman out, so you're dealing directly with your own healthcare needs and not having to go through the carrier. We're so trained in this healthcare system, we go where the doctor tells us, we slap our insurance card and our credit card down, and we don't even ask questions. What Sedera has done for my family, it's trained us to shop for our healthcare needs just like we shop for everything else. You know, I think a lot of people are drawn to Sedera because of the price. I don't like to sell on price, and I don't like when people buy on price because most of the time you get what you pay for. I do think Sedera, though, has the best value. So I tried not to allow them to make the leap just based on price. I want them to understand the product, and I think once they do, they love it. But it's really hard for a business owner to go back to the way it was once they've experienced the transparency, the cost savings, and the freedom they have with Sedera. Really haven't had a customer leave once they've had Sedera. I've had a hard time finding a negative review about Sedera. But I think the biggest tell when you're looking at any organization is, are people loyal to them? Do they do what they say they're going to do? Do they have a good product? And do they do it timely? And Sedera does all three of those things, and they do it well.
I just want you to know, soup to nuts, we have thought of it all between education, enrollment, reporting, reminders, the customer experience. We even have great support for HR and a library of resources. And of course, as a employee benefits advisor, I have the ability to bring voluntary and ancillary benefits to really round out this strategy. I want to leave you with this quote. It's one of my favorite ones. Buckminster Fuller was an inventor, a futurist, a strategist, just a really, really smart guy way back in the, I think in the 40s and 50s. And he's famous for saying this: you never change things by fighting the existing reality. To change something, build a new model that makes the old model obsolete. So I hope what we've done is given you a way to have your eyes open to a different way to bring real health care to your employees, and showed you, even some existing things that already are in place. All you have to do is put them together the right way, and allowed you to envision a future where you can afford to have your employees have true personalized care, way better, making the insurance company model obsolete. Here's where you can connect with me. Call me, email me, scan my digital business card, and save me to your contacts, and let's stay in touch. Let's check the questions one more time before we head out. Oh, thank you, Joe. Oh, that was a great question. There really are not a lot of limitations. And as a matter of fact, even with Sedera, since Sedera is not insurance, you're not required to contribute to it. You have all kinds of flexibility. If it's something you can afford, then great. Pay for 100% if you like. Or if you want to structure it so there's different classes, like Jason mentioned earlier, a full-time class, a part-time class, whatever. If you want your seasonal employees to have access to this, but you don't want to contribute to it, it's okay. You can structure different strategies for different classes. You have lots of flexibility in this model. Anything else you want to add to that, Jason?
Yeah, just to finish the answer on Joe's question, are there employee or owner dollar limitations for contributing to HRAs? For ICRAs, no, there's no maximum. The employer could choose any amount. Now, the key here with owners, unless it's a C Corp, an owner can't receive any tax-free benefits of any kind. And so, if it's an S Corp partnership, LLC, owners can get the money from the company, but it would just be added to their K-1 because it would be taxable. Kim's question, and if an employee chooses Sedera, can the employer still give money to the ICRA for employee to pay for DPC? And then she adds, because ICRA funds cannot be used to pay for Sedera, right? Yes, the ICRA rules are still in motion in terms of what ICRAs can reimburse. And the IRS is being conservative so far, but is adding things on a yearly basis. So you are correct. DPCs, in fact, I think there's proposed guidance already. I should have double checked that before this webinar. There's proposed guidance that was issued a few months ago regarding DPCs being funded through ICRA. And I think Sedera, it will be an ICRA reimbursable expense in the near future already. In fact, I'm sure some people are already relying on the proposed guidance.
One more question from Joe about C Corps.
C Corp owners, yes, C Corp owners can receive tax-free benefits since the C Corp isn't a pass-through tax entity. And so anyone who is a C Corp owner of any amount, whether 1% or 60%, that person can get HRA money tax-free if the employer pays a benefit, all or in part, like DPC, for that employee, can be tax-free. And then a C Corp owner could participate in a health FSA on a tax-free basis. So that is true for C Corps. That would not be true for all the other business entities.
And Tom, I personally see that small business owners and small businesses need employee benefits. I go back to my scenario that I played out earlier. You've got a great loyal employee. They're crucial to the success of your small business. But if you don't have a benefit strategy, then something happens to them. They get a big medical bill and they feel like they have no choice but to go find a different job with quote unquote insurance. I think this is way better strategy. And there's a lot of small business owners who are not being presented with this strategy because it's not insurance. And, insurance people, they are salespeople, right? And as a matter of fact, it's not a bad thing. I'm in sales too. Throughout this webinar, I've been telling you, I can do these things for you. I can be your TPA. I can be your advisor. So I'm selling myself too, but I find that with insurance brokers, many of them only want to sell insurance and they don't want to consider a non-insurance strategy like this. So I don't think that a lot of small business owners are getting the message that this is an option. That's why we did this webinar, and I'm so glad you participated in it. I can't believe we blew through the hour that we had allotted. Not uncommon for me to just blab on and on about things, but I hope you got something out of it. And like I said, let's stay in touch. And if you have more questions, don't hesitate to email me and we'll continue the conversation soon. All right, guys, have a great weekend. Bye.